Okay. So superficial and cutaneous mycosis. And as I said the other day, many times you will see infections of the skin as a major part. So we'll start with the skin and then deeper tissues and so on and so forth. This is one typical case that you may see a young child with enormous, most like plant-like, tree-like things growing. And there's something to do with mycosis, something to do with immune system, and then fungal infection. So if you were to look at it, if I was to look at it and want to establish a differential diagnosis, so most likely I'm going to think of skin infection, of course, that's very clear. And drug reaction can also show a picture like that. And immunodeficiency, most likely, yes, because immunodeficient patient, especially given the age, but he's a little bit too old for the immunodeficiency. And then again, it could be cancer. Anything that you can't find, it could be cancer. And it can also be metastasis of cancer. So cancer can spread and have problems. But anyway, you don't have to be very specific that a person really has to have something like that for you to figure out that it's a fungal infection. But again, this physician wants to test you, want to make sure that you do have fungal infection. And that may be true. I'm sorry? Don't worry about that. Forget it. We'll talk about it afterwards. This is more important than all other things. Okay. I want you to pay attention to me now. Okay. There should be a attendance sheet somewhere as well. Is there an attendance sheet here, Answer? Yeah, that's important. Now, the other thing, I'm still reviewing your individual project and what deficiency I noticed in so far, what I've done so far, that none of the students did take any time to look at drug delivery, and even those students who were working on antifungal, they didn't even bother to look at what are the drugs in the market. So these are 2.5 points taken away straight away if you don't have any novel drug or anything that I can Google and you cannot. But you can see from here, while we talk about fungal infection, and you will see in this case especially, we discussed about the structure of fungi, and this slide shows you the main classes of antifungal drugs that we use clinically today. And one of the first class over here, A, is azole, and these are the names of fluconazole. And I think I'm pretty sure that you are familiar with all these drugs over the counter and even prescription drugs available. But if you remember, we talked about the production of ergosterol instead of a cholesterol in fungi, and these drugs block the production of ergosterol. And once they do that, they will cause accumulation of a toxic sterol intermediate, which results in cell membrane stress, and the fungi dies. So we are interested in killing the fungi. Number 2, B, you will see these are polyenes. The typical example of the drug is amphotericin B, which binds to ergosterol and therefore forms pore in cell membrane. We talked about osmotic kind of eruption or disruption of microorganism when something even by immune mechanism pokes pore into the cell membrane, and that may kill the cell. So you can see polyenes are there. Third line of drug are 5-flucytosine, and that inhibits DNA and RNA synthesis. But keep in mind, this is more of a stoppage of macromolecular synthesis, nothing to do specifically with fungi. It could be used as anti-cancer drug as well, because mechanism is the same. You want to stop that cancer. So when we talk of anti-cancer drug, we will also talk of 5-flucytosine. Then we have echinocandins, which are caspofungin, very important drug for you to remember. And what it does is that it inhibits the catalytic subunit, which is there in the cell wall. So it kind of disrupts the cell wall integrity. So if you compare that with the antibiotics, where, if you remember, I showed you some of the drugs acting on cell wall synthesis, some of the drugs making pores over there, some of the drugs binding to chromosomes, right, especially ribosomes, and then stopping synthesis and then acting at nuclei. So you will see over here the whole idea for the main classes of antifungal drugs are such that if you look at the structure element and you look at the way they cause disruption of the cell wall synthesis, it's very obvious that they may have side effects if you are not very specific in terms of picking up those agents that will destroy the cell wall or the structure of the fungi and not our own cell. So you can see from here this picture that all the way from the cell wall to cell membrane and even structures element which are there in a typical eukaryotic cells are important for fungi. Now, some of the key points, as I may have mentioned here, just a recap of what I said the other day, that most of the mycotic species that we deal are filamentous. They form spores and mold, yeast, and higher fungi. And as we discussed earlier, that and somebody asked me the question as well, they are pathogenic. There's no such thing as non-pathogenic once they come and attack you. They also cause allergic reaction, and some of the things, if you remember when we talked about hypersensitivity, at that time we talked about mycotoxins. So these are some mycotoxins that are released by this fungi can lead to allergic reaction. And again, when we discussed about the agents that are there in terms of causing 4 major groups, we discussed that the other day. And today we'll talk about superficial mycosis, meaning that the very first outermost layer that is protective, that's basically skin and hair. Okay. Now at this point, what we need to understand is, like viruses, these fungi have tropism. And what is tropism? What do you understand by tropism? Sorry?
Attraction.
Say it louder.
Attraction.
Attraction to what?
Either chemical or light or.
Okay. Attachment to the tissue. So tropism is that the microorganism has some receptors that are going to tie up with the corresponding. So that attachment affinity between two is called tropism. So they have this tropism for attachment to skin. But when I say skin, so probably I don't mean the general skin. I want to talk about a little bit specific as to what do they attach with. Now, cutaneous mycosis are basically infections of keratinized tissue, right? And include dermophytes. So what we do is that those fungi that attach to a particular layer, which is keratinized tissue, if you look at anatomy of the skin, they have tropism for that, and they are called dermophytes, dermatophytes. So these are the one dermine skins, and it's like attachment to that keratinized layer. Whereas subcutaneous involves infection of subcutaneous fascia, muscle, and deeper epidermal layers. So they have to have those corresponding receptors on themselves and on the other tissues that will allow them not only attachment potential, but also allow them to be penetrative and invasive as well, okay? And then systemic, of course, systemic means there's something you can inhale or go into your blood. Systemic is systemic, right? So remember, depending upon the size, the smaller it is, the easier chances are they're gonna go and enter into the respiratory membrane. And if you remember respiratory membrane, what are the layers of respiratory membrane? Respiratory physiology. Okay, anybody? How many layers are there? Say again? I don't know who's talking. You have to raise it. Okay. 3, correct. What are those layers? You're right. Okay. Remember that, I don't know, PCOA. Did you hear of PCOA? Where is Ashley? I think he was a part of the, I've not been successful in picking up. Whenever I ask for the topic, nobody's speaking. When I call somebody, he's not there. And she would tell you PCOA is a new exam that was introduced last week. And the idea for that is that we want to prepare you for NAPLEX and also prepare you for any other test. So you need to know all these things. This is one of the, what they do is that they send me as a course coordinator. So what do you want your students to retain for 4 years? Some of the questions I ask you in the class, they're going to be there. It's mile marker as well. So respiratory membrane is one of the most important questions they want you to know at all times. It's not a, hey, I got an A, forget it, I'm not going to care that. That's not the case. So it has to be something, because once I talk about that, and it's a common sense thing. You know, there's an alveoli, which is a sac. It's lined by epithelium. All epithelium are sitting on the basement membrane. And on the other hand, there's a blood vessel that has an endothelium that's also sitting on the basement membrane. There has to be an oxygen and carbon dioxide exchange. They have to come closer to each other. So 2 basement membranes will fuse to form 1. So you have epithelial layer on one side, 2 basement membranes stuck together, and endothelial on the other line. That's where normal flow will take place. And there are pores there. Now, if you got pneumonia, for example, the pathophysiology of pneumonia is because of the edema, there's fluid in between. So that will increase the distance the oxygen has to travel. So you'll have cyanosis because oxygen cannot travel because you increase the distance. So this is the basic pathophysiology that you need at all times. Okay, and they're going to come back over and over again in different type of tests. Okay. Now let's go into 2, and again there are quite a few tables in your book, but I want you to make sure that you understand that, and difference between superficial and cutaneous mycosis. Now, when we talk of superficial mycosis, we basically are talking about outmost layer of the skin and the hair, right? And I know I taught you the layers of the hair as well, and probably I'm not going to quiz you for that, but I would recommend that you can go back and look at the anatomy of the hair, because that's important in terms of fungi causing disruption. I'm pretty sure all of you will be interested. Why my hair is thinning out? Why do I have this? I want to color my hair. I want to have my glossy blah blah hair. So all these things have something to do with the anatomy of the hair. It's in your interest that you know that, and especially for the drugs. Okay, cutaneous, a little bit deeper, and epidermis and its integuments. Remember when we taught you skin, we said integumentary system, and that included hair and nails as well. So skin basically has hair and nail as a part of the integumentary system. Now, a recap of what I was talking to you earlier. And let me see if I can enlarge that. This again will be very important for you to know, but you can see from here, this is epidermis, dermis, and hypodermis. And in epidermis, we have the topmost layer, which is stratum corneum. Then we have granular cell layer, we have spinous cell layer, we have basal layer. Okay, and then you can see all these anatomy here. And on the other hand, you will see that there are specific cells like fibroblasts over here, collagen fiber, capillary vessels. What was the significance of collagen fiber as a part of dermis? I remember I talked about it as a part of pathophysiology. What is the significance of collagen fiber in the skin as a part of dermis? Okay, let's move on. That's fine. I don't want to burden you because you have many things to remember, correct? Okay, but I'm just hinting you that all these questions, basic physiology, will come either in milestone exam or in PCOA. Okay, so be prepared for all these type of questions because it's very important. The importance of elasticity in the skin wrinkling. Even if you go over the counter, why do people take collagen? They take collagen because they don't want sagging of the skin. They don't want the skin to wrinkle. It's a big industry there. So you should know as pharmacists, where is the location of the collagen and what possibly can you do? Okay, so that's important for us. Otherwise, there would not be any difference between me, you, and any lay person in knowing what is the basic physiology for that. Anyway, the other important thing I don't want to go and teach you again was the skin where the pigments are located. So pigments are located, right? And also keep in mind that, and actually there was, I don't know whether you were interested, there was a lecture by Dr. Hardy, cultural sensitivity in pharmacy, and one of the things that she was mentioning was that she was saying that somebody say an African American patient is saying that I can see jaundice on the skin. You cannot, or looking at cyanosis. So there's something that you have to keep in mind in terms of physiology. What is jaundice? What is cyanosis? Right? So that's your basic understanding. Otherwise, you'll get confused. And this picture, when I showed you, was there in terms of environmental factor in person having lighter skins and darker skins. Of course, that doesn't take into account in terms of the movement of people with the advancement of travel industry. But keep that in mind. When we talk in skin, I'm going to talk about hyperpigmentation. I'm going to talk about hypopigmentation. If I was to ask you, this particular fungi is messing up melanocyte, I expect you to know where the melanocytes are. Okay, so this is where some of the clinical symptoms that you will see. Now, if you compare that, again, epidermis, sedum corneum, dermis, and subcutaneous fascia, again, any fungi that's going to pass through that is going to either attach to the skin or in the hair, and there's a gap over here to come down and mess up the base of the hair. And also keep in mind, every hair is supplied by the blood vessel and nerve, right? And then there's a secretion as well that's attached in terms to the glandular secretion. That's why all this hair industry talk about the shine of the hair, the nutrition of the hair, which is true. But again, many of the things that are there in the market, as I said, may not be approved by FDA. It may or may not work. Now, other than the epithelial layer over here, there is an epithelial layer in the lungs as well. Remember, I just told you respiratory membrane. So you inhale spores of fungi, and that then go into the lungs, get absorbed over there, and then there is another layer of endothelium here in the kidneys, and so on and so forth. So you can see most of our organs are lined by epithelium and endothelium. Right? Very basic histopathology, very basic histology that you need to know, especially even for drug absorption. Why is it, if I was to ask you that you have 2 suppository to be given to a patient, if all female, 70 years of age, you're going to go either for vaginal or going to rectal, where will be the more absorption and why? So we're talking about the epithelium absorptive power. If I say it's a sublingual absorption of the drug. I want you to know what kind of a epithelium is there to get that absorption, right? And why is it not taking place in stomach? Why is it taking place in jejunum? Why is it taking place in ileum? So on and so forth. Because for any drug absorption, there has to be a layer, right? And that also will come into play one of the things that we talk CAM. And what are CAMs? This will be the 10th time I'm going to ask this question during the last 1 year. Yeah. Why are you? Very bad. Very bad. So this means that I just said there's no point you getting an A with me and not knowing the subject. Points don't matter. You need to know the subject. Yeah.
CAM is the junction.
Name it. I mean, this is, I said 10th time.
Cellular adhesion molecule.
Correct. Cell adhesion molecules. CAMs, cell adhesion molecules. Because if you don't know the anatomy of cell, you would never know how the drug is going to pass through the cells. Okay. I remember somebody was telling me that, my professor just gave me the study notes and instructor guides, and I just passed that, but I don't know what pathology is, what physiology is, and what those are. Very bad type of learning. Okay. We call it KG level of learning. Hey, I'm going to give you candy. Can you spell out this word for me? Okay. So superficial mycosis, as the name starts, fungi that colonize the keratinized outer layer of skin, hair, and nails. Okay, very important. Now, why would they have no host immune response, or even if they do, they elicit little host response? Why? So that's 1 point credit that I can give you if you answer me that. You have to pay attention, right? Otherwise you waste my time. I said, why is it, many times people say, hey, and then, oh, point, then say, okay. Okay. Why is it that you have either little or no host response by a fungi which is going to cause superficial mycosis? Yeah. Got it. Very good. Correct. He's right. Because the cells of immune system are not there. That's why. Because again, if you look at the anatomy of the skin, they are a little bit deeper. Sometimes there is only one cell that can go and climb up, and that's where you get a little response. What's the name of that cell? Messi is not a cell. What is the name of the cell that would cause the little bit of immune response that I just mentioned about? Say it again? Well, I would want to be a better word, but you're right. It's a dendritic cell. The dendritic cells in skin are called Langerhans cells. Okay, you got it. We'll give you a point here. Okay, so these are some of the anatomical terms in terms of where the cells are and why would they do in response, okay? And they are usually of the cosmetic concern, so they are easy to diagnose. And the reason is because people can see their skin and people can see their nails and hair, so they get panicky. They want to bring it up to the physician for care. And that's what the big industry was. Okay. Now, one typical disease that we teach, who did topic on malassezia fervor? Don't tell me that that person is not here. Malassezia fervor. Okay. Lucky me. So this was one of the topic given to one of the students, very important, because it may affect 60% of population. And Pityriasis versicolor is a common superficial fungal infection, right? And this particular fungi, in our physiological term, we call tinea. So you'll see a lot of drugs over there we call tinea. Okay, and one of the things this particular virus has is lipophilic yeast. It's called lipophilic yeast, Malassezia fervor. What is the significance of lipophilic yeast? Had it not been lipophilic, it would not attach to the skin because skin has lipids. So it has to be lipophilic. Okay, simple. Okay, now, if you, as I said, one of the commonest tests that we normally do for these fungi is that we scrape the skin and look under the microscope. Okay, now, when you look under the microscope for Malassezia furfur, it appears like a cluster of spherical or oval yeast-like cell about 3 to 8 micrometer in diameter. Remember I said about the sizes of the respiratory membranes, the respiratory and the glomerular membrane and the blood-brain barrier. So pretty much know what is it that can pass that barrier. So if you look at these yeast cells, sometimes you look at the branched hyphae, and when you were to culture them, it basically cultures and appears like a cream. And this is a typical culture that you see, as I was given example earlier, was that when your bread or milk or anything sitting over there for a long time on the bench or the table will have fungal infection. That kind of a gluey, creamy-like thing that appears on top of that. And that's what you saw in the first impact slide I showed you, the young boy who had all the face covered with a fungal infection. So that kind of erupts over here. So this is a skin scraping, and we call it PAS skin scraping. That's a stain that we normally use. PAS stain scrapes, and you can see it comes in different types. So there's circular, spherical, and sometimes a branched hyphae as well. So you can see the branched hyphae over here. So this is a typical skin scraping of what we call a tinea versicolor. If you were to look at under electron micrograph, you see Malassezia fervor, and it has, let me call it like a typical example. Let me see over here. It's like a lip-like collarette. We call a lip-like collarette over here, lip-like collarette over here, lip-like collarette over here. That's a typical pattern where we call it initiation of budding. It's just like budding out, but just begun to bud out. So that's what it is in terms of lip-like collarette. So if you were to be asked that under electron micrograph, you see a fungi, and the person reporting is that it is a lip-like collarette, and you're given 5-6 fungi, so make sure you pick up Malassezia fervor. Okay. Why is it cutting on the back? So that's another important thing that you will see, that this is a sporostrix. Again, remember I said when we talked about the basic lecture for fungi, I said that there are conidia, and then there are orthoconidia. So these like spores, and they are like opened up in the atmosphere, so they can go and be dispersed in the air, and you can inhale. So that gives an example for one of those structures that we normally see. Okay, now this is a basic immunology, and I'm not going to talk much about that. But those of you who are interested, they can read out the immune response to fungal infections when we did that. So you will see how would an immune cell, like, for example, a dendritic cell or Langerhans cell, can look at the breakdown of those fungal products and how they are presented, and what kind of immune response that you will see. So you'll see both a cell-mediated response, and you will also see a humoral response where you get a antibody production for many of the fungi. So this is just a recap of what we had discussed earlier as a part of immune response to fungi. Now, for epidemiology, pityriasis versicolor is known as a disease of healthy person, but it is present, prevalent in tropical and subtropical regions. Because remember that why do we get athlete's foot? What is the commonest cause of athlete foot? If you were to go and say, hey, to your physician, why do I get athlete foot? What would the answer of your physician will be? Why do you get athlete foot? Yeah. Not changing the socks. Okay. Correct. But dampness. That's what the problem is. So dampness, because you get problems of fungal infection because of dampness. So many people who naturally have finger webs that are kind of stuck together, right? So sometimes they ask you to put something in between so that there's air circulation going on. And all other things that she's talking about, socks and this and that and shoes, are secondary to the primary thing, the dampness. Anywhere, any part of the body which doesn't get the fresh air would likely develop the, what do you call, fungal infection in terms of cancer. Okay, now the other thing you see over here is young adults are most commonly affected. First, is not found as saprophyte in nature, and it's not been documented in animal, but again, things can change. Human infection is resulting from direct or indirect transfer of infected keratinous material from one person to another. So if I tell you this is the mechanism of transfer, so what comes to your mind? How can you avoid that? What is it that, I mean, you'll understand as a pharmacy student that that's what the transmission is. But if you were to tell to your patient, you're going to say, hey, don't have direct or indirect contact with infected keratinous material. The patient would not understand. So what is it that you're going to tell the patient? Yeah. Well, the thing is that the only thing that you would tell the patient is that select a good barber, right? Don't share comms and all these. That's what you're going to tell, because it's transmitted through that. One of the commonest things that's going to go for getting problems in terms of infections for the hair, and this kind of thing is when you share the keratinites. So that means skin and skin, what do you call, scraping. These are the chances. You go for the shampoo, you go for the hair. That's why I said to change the barber and get it like more sanitary thing. But you should not be sharing comms and all these things that come in contact with you. That's pretty much understanding over here. So you can pass it on, because how would people know that other person, especially in the barber shop? I mean, you can imagine that I don't know, what kind of sanitation is required for them, but you can see that some of the machinery, hair clippers, how are they going to get rid of those fungi? I'm pretty sure that the blades, they can have new blades, but I'm not sure as to what kind of FDA regulations are. But this is one of those places that you may acquire, and there are chances for you to blame them, so to speak. Anyway, now if you look at, as I just told you, I gave you the skin map color of the people as well, and also told you that the things may mean different if you are going to talk about culture sensitivity and the skin color and skin hair. So you should know what are you looking for. You cannot be looking for jaundice on the skin. You have to look at the jaundice sclera. You cannot be looking at the sinuses on the skin. You have to look at the sinuses on the nail beds or in the mouth. So keep this in mind in terms of the skin color. But anyway, they appear as small hypo or hyperpigmented macules. Okay, again, I talked about different lesions of the skin, and I would want you to go and look at the slide that is there in the skin, where I talked about macule, papule, pustule, carbuncle, all these kind of terminology that we normally use. Patients may not use it. They will just say an area, they say lesion, but the physicians would use it. So it's your interest to figure out what's going on. Now, they usually appear on upper trunk, arm, chest, shoulder, and almost any part of the body. The lesions are irregular. They are well demarcated patches of discoloration. And I mean, I don't need to tell you, if I just told you that if this fungi is causing hypo or hyperpigmentation, this is going into the deeper layer where there are melanocytes. Simple, right? So you should start thinking that these Malassezia fervor interfere with melanin production, right? Then again, lesions are usually hypopigmented in dark-skinned individuals. Again, as I said, it will be difficult, whereas in light-skinned patients, you will see they appear like pink or pale brown. And they obviously become obvious when they fail to tan of exposure to sunlight. So these are some of the issues that we normally see in terms of same microorganism, Malassezia fervor, causing infections into two different sets of people who have a different skin color. Again, little or no host reaction. Lesions are asymptomatic, and the only thing that you will get pruritus. Right? Again, I'm going to ask you, what I would want you to know, I'm going to ask you in the exam is why you get pruritus. And I can tell you right now, you need to know where are the nerve endings in the skin. So if you know where the nerve endings are, then you will be able, if a fungal infection reaches that part of the skin layer, that's what you got pruritus for, okay? If you get infection of the hair, we call of the hair follicle, anatomy of the hair, we talk about that. Folliculitis, perifolliculitis, and you can have an abscesses as well. Again, look at the anatomy of the hair. This is a typical presentation on obviously a fair-skinned person. Pityriasis versicolor. You can see this hyperpigmentation or light brownish kind of a thing is a fungal infection. And then again, as I said, that the previous one was Pityriasis versicolor, but there are different types of these infections, and most of the time we give them a specific name. So we can see from here, this particular infection we call rosacea. So it's like a rose because it appears like red and scaly, and many a time it also, you will see as I move along, that appears like a ring, right? And most of the time they appear at areas where like axillary armpits because of the dampness over there, or appear in the underwear lining where groin, where the chances are because of the dampness they appear. So this is a typical kind of presentations that we normally see. And as I said, depending upon age, you can see from here, huge ring. We also, I mean, that's not a good word, but I think we use that. We also call it like ringworm. It's not a worm though, right? But you can see it like appears like big patches over here and here, over here, over here. Sometimes if you pay attention, it's red, rosy, scaly as well, because the reason is that the skin is dying and things are being peeled off. So that's a superficial fungal infection that we normally see. Again, many times, depending upon your age group, depending upon your immune response, depending upon your pre-existing condition, like if you're diabetic, so you may show a different pattern altogether. So you can see again ring form things, and sometimes it gets infected as well. So again, it gets infected, and then you may have exaggeration of whatever kind of lesion that you normally see. And some of these tinea, and I'm going to give you the name for that, appear at a very specific location of the body. And many a time, the clinical picture is named after that. Again, you can see very commonest kind of infection. As things now have changed, people are more sterilized using the what you call blades, which are more sterilized, and they are not being used over and over again. Otherwise, the shaving areas of the human or female body is basically another thing that would allow, because of the continuous irritation and scraping off or injury, that can allow these fungi to move in and cause damage. So you will see that also in terms of how would these microorganisms get into the system. So as far as lab diagnosis is concerned, I said we do the skin scraping, look under the microscope, we put a drop of 10% KOH, and sometimes we add chalcoflower white. This is a typical thing that I'm going to talk about over and over again, very unique for fungi. And if you happen to work in a dermatology clinic or in a ward, they do it routinely. Okay. The other things that they would do is that hematoxylin eosin stain and PAS stain, very commonly done. Those of you who have ever worked in lab or tissues, and most of the histology is done on hematoxylin eosin stain. The third important, and this is good that I'm bringing up all these lab diagnoses, because this is kind of a standard lab diagnosis that will appear for almost everything that we see. One other thing that we do is that we have a wood lamp. We have it in our lab as well. So if you put at the lesion, it's gonna fluoresce. So it's gonna give like shining, right? So your lesion, look at, and it's gonna shine. So that's again very common thing that the physicians keep it, and dermatologists keep it. Okay. And then of course you can also culture. We talked about culture other day, and Seborrheic agar, and I said with or without antibiotics that you can normally use. Now, for this part, we're going to go a little bit detailed, that I would want you to name the drugs as well and their mechanism of action as well, as we did for virology. So virology and mycology are such two subjects that we're going to go in drugs as well, because they would not be taught to you again. So in this case, any disease can be chronic or persistent, and that's again important. And I gave an example for athlete food, so we come over and again. We give topical azole, and if it's in the skin, like dandruff. So dandruff is an infection, a fungal infection. So we give selenium sulfide shampoo. If nothing works, then we give oral antifungal drugs, and these are ketoconazole and itraconazole. These are very commonly used, but again, they're very expensive, and I think 6 to 12 weeks, it takes a lot of time for them to start kicking in. The second one is cutaneous mycosis. We talked about the superficial, and we divide that into dermatophytic fungi. Again, dermatophytosis, that's a term that we normally use, or non-dermatophytic fungi, which we call dermatomycosis. So these are like technical jargon that we normally use, but if you understand the anatomy of the skin, so we are now getting deeper into the tissues as we move along. Now, I don't know why my slides have been cut. Let me see if I can repair that. Probably I cannot. Okay, that's better. All right. So you can see dermatophytosis is basically a disease where we have all those filamentous fungi. So some of the fungi form filaments, and some of like circles. So these filamentous fungi typically are three: trichophyton, epidermophyton, and microsporum. And next time you go and buy yourself a cream for your athlete's foot, you will see that exactly the name will sound familiar. They will talk about some of the are exactly by this name. So these are their trichophyton, and all of these two are phytons, and then you have microsporum. And these fungi are called dermatophytes. So they are dermatophyte because they all have an ability to cause disease in human and animals as well. So you can get it from your pets as well, or transfer it to your pets as well. That's important in terms of dermatophytosis. Now for pathogenesis, as we've been talking over and over again, these fungi can invade skin, hair, and nails. So nails come in because nails are a little bit deeper and they're hard to penetrate. But once the fungi go to the nail, it's difficult to treat. And they are also keratinophilic, but they're not only attached to keratin layer, but they also lyse the keratin. So they are keratinolytic and keratinophilic, right? And they can break the keratin. So keratin is a protein there. So they have these enzymes that are going to break them apart and cause damage. But that will show you the penetrative power of this. And then depending upon which part of the body is infected, if it's hair, it's going to go and break your hair. Or if it's your nail, it's going to go deeper part of the hair. It depends which part of the hair, nail, skin anatomically they are invading. And that will determine as to what is the clinical picture of the disease. Now, remember I said that they are also called tinea. We also call ringworm. Clinically, we give them a different name when they affect a different area. For tinea capitis, scalp, eyebrows, and eyelashes. Tinea barbi of the beard. Tinea corporis of the smooth or glabrous skin. Tinea cruris of the groin. Tinea pedis of the foot. And tinea unguinum for the nails. The technical term for the fungal infection of the nail is called onychomycosis. Onychomycosis. Very commonly asked question, onychomycosis. This means very specifically for the nails. And again, as I said, depends upon how penetrative they are, but they all are there in terms of tinea or the form. Now, as I said earlier, so depending upon which part of the body they are affecting, so you can see tinea corporis, tinea versicolor. Each one of them has a particular liking to attach to the keratized layer of that part. Okay, I'm not going to go in detail for this course to teach you exactly what are the receptors, what are the corresponding receptors, how you block them, blah, blah. But at least you should know by the name that which part of the body do they infect and what would be the difference in terms of the breaks that we normally get. And again, you will see that most of the time, all those areas either are covered or they have dampness. So there is a sweat element over there. And then again, sanitation and cleanliness also important role in terms of what's going on in this area. Now, again, the same thing. You will see different infection name, and these are the clinical sites that we normally see. One important thing that you will see, I gave you the example of inguinum, is that if I was to ask you glabrous skin, so we're talking about the tinea corporis, and that's the inguinal area, like a diaper rash for the babies. So it's very common for both male and female to have infections in that particular area. Now, as I said earlier, if it affects the hair, again, other than the typical hormonal baldness, which is known differently for male and female, if it is alopecia, I think there were a couple of slides for alopecia. We can go back and look at the skin, what are the effects for alopecia. But again, hair especially is important in terms of fungal infections, and we do treat them as more than selenium sulfide shampoo. For tinea barbi of the beard, you can see again, it can get really infected, and it's very laborious to treat and may cause problem. Onychomycosis, as I said, depending upon how deeper it's going to go into your nails, very difficult to treat. And once you have this situation, forget local treatment. It's not going to work. You have to take oral. There's no other way. Same thing, you can see the discoloration of the nails, the deformities over here, thickness of the nail because the fungi is growing. And of course, a podiatrist will be there to help you. We talked about ringworm. I gave you, that's a kind of, not a worm per se, so don't get confused. It's not a worm. It appears like a worm. So that's what the idea is. And that's again very common, as I said, area for both males and females in terms of the, we call it underwear area, where you have all these infections coming up and that needs to be treated. If you look at the spread of these particular fungi, you can see that they have microconidia or microconidia, and then depends upon how it's going to be passed on to the other people. And when we grow them, we want to make sure that we can spot, because as I said, it's very difficult to treat. And many times sanitation and personal hygiene is very important. But what you need to know in terms of their infection, when you talk about, other than I told you about the, what do you call barber and comps and so on and so forth. One important thing is that sometimes the infection may be spread by fomites. So fomites, basically, the best example for us will be, because hospitals maintain is like hotels, where they have want to share the linen, or want to share what you call towels and so on and so forth. You never know how good their decontamination is, but that's where it's going to spread. And then again, depending upon which age is there, what is the underlying condition that can exacerbate the whole situation, like diabetes, for example, they're going to have repeated infections. Okay, now we already talked about that, but you can see that it really accounts for quite a lot of percentage. So we do see many of them, for example, in Tinea capitis in school children, and then in the world population as such is very important, because dandruff, everybody goes through that. Sometimes people have chronic dandruff. So that's a fungal infection. So that's where the struggle is. Okay, now basic microbiology, I don't want to go and tell you that the extent of disease depends upon the inoculum size. So the inoculum that you get will depend how severe will be the disease. Higher the inoculum, the severe will the disease, right? Again, is one of the factors that we have in terms of immune response as well. Few slides, a recap for infection of the hair, because I'm pretty sure many of you may be interested what's going on. So you can see from here, A is a ectothrix, where is a hair infection. Then there is an endothrix, which is also a hair infection. And then there is a phavic hair infection. So you can see it's a big field. So things are not that simple as you think. But next time you buy yourself any help in terms of maintaining your hair, so you will see, look at it and look at the mechanism of action of the drug. It will explain that to you. And this is actually the culprit. So this is the fungi there. It's kind of clung to different, over here it's like externally sounding, it's penetrative. Over here it goes to the base and kills the root of the hair and cause problems. If you were to cut that hair section, that we normally do, so you will see over here especially arthoconidia. So you see the arthoconidia? So these arthoconidia from one hair are going to jump to other hair. Okay, and these are the arthoconidia that you're going to comb your hair or share whatever gadgets you're using or wherever you're going for them to use, and transfer it to other people as well because of their size. And you can see these ones are deeply penetrative, and this is especially for ectotric infection. Tinea capitis, again, will be a baldness over here in terms of patches, other than normal testosterone effect in male, which is more of a genetic issue in terms of these occasional patchy lesions on the skin that you will see in terms of especially Tinea capitis by M. canis. Interestingly, this is a high darkly pigmented macule, and again is a Tinea nigra, and you can see it can also appear on the hand, right? But of course, it's not that simple, because as I must have said many times, that we should not, actually we'd rather refer it to the dermatologist, because things are not simple. If you were to cut section over here, you can see these tiny little tinea. They are basically going into the deeper part of the skin. So they do the skin scraping and look under the microscope. Lab diagnosis, pretty much the same. So from now onwards, whatever I tell you in terms of lab diagnosis, either is going to be skin scraping, for KOH or PS or periodic acid shift or HNE. When we talk of woodlamp, we talk of the culture for severoid agar, and then any specific other thing that are there, but they're pretty much common for most of the fungal infection that we normally see. Okay, very rarely you need to culture, but again, remember, severoid agar is like a standard over here in terms. But the problem is that you see that it takes 7 to 28 days for the colonies to appear. So what is the clinical significance of that? If I tell you this particular will take 7 to 28 days, but yeah, no latent period, no latent period. That's more of a virology. This means chronicity of infection. This means infection is going to stay for at least 1 month. Okay, so the therapy as a simple, I mean, again, mycology is easy to remember because if I say oral, if I say local antifungal drugs, I'm talking about azole, and these are the ointments and cream for azole, anything that ends with azole. If I talk about oral antifungal drugs, I'm talking about very specifically griseofulvin, itraconazole, and all those terbinafine. So these are the 3-4 important drugs. Every time, each time, when I say topical, I mean azole. If I mean oral, I talk of these 4 line of drugs. And we already discussed in the beginning that these are important. And if you treat them, there you go. You do see the result for antifungal drugs, that it can basically completely eliminate that infection. So it's one of the success stories that we have. Okay. Any questions?